All right, good morning and welcome to the June meeting of the Louisville Metro Board of Health. This meeting is virtual only and being streamed live on Facebook. The chair calls this meeting to order and trusts the summer season will be a refreshing time for you and your family. The chair has one action item and a few important announcements and other actions to begin the meeting prior to our perspective session. And welcome Dr. Smith, who clearly is a member of our community advisory board and is globally recognized for the work he and his team have been doing over the years. So moment about that in just a bit. So here we go, folks. The minutes from the May meeting have been distributed. Are there any edits or comments for those minutes? If not, the chair will entertain a motion to approve the May 2024 minutes.
So moved.
Motion to approve.
Thank you.
Second.
All those in favor, aye? Or,
Aye.
Aye.
thank you. Abstentions? Motion carries. The May 2024 minutes are approved as distributed. Okay, for your notes, guys, and I think you have it in my update. July's meeting is scheduled for Wednesday, July 10 at 8 a.m. This meeting will be virtual only. It is a critical meeting due to the election of new officers, but the good news is we're going to try to get it over in the shortest time ever recorded. There are only two agenda topics. One is the election of officers for the next term, and any urgent, emergent, important motions that need to be effected prior to our September meeting. As you know, there is no meeting in August. And so therefore, the next meeting will be September 4 at 8 a.m. in the very well qualified hands of Dr. Bautista Cervera. Okay, now an action item. It is the chair's distinct honor to nominate Dr. Patricia Bautista Cervera, our current vice chair, as chair for the upcoming term, as well as Dr. Emerald Eccles, Ph.D., as vice chair, as recommended by Dr. Bautista Cervera. Is there a second?
Second.
Thank you. Is there a discussion? As I watch Hollywood Squares here. I see none. All in favor, please raise your hand. And Dr. Eccles, you can vote for yourself. You can have confidence in yourself. All opposed? Abstention? Motion carries, and congratulations and big hugs to all. Let's see here. Moving on, the chair notes that Deputy Mayor George is working with the mayor on recommendations for candidates for our open board positions. We have several that expire very soon. And I would let everyone know that the way this works is the mayor recommends and generally a diverse candidates, and that means in terms of geography, ethnicity, background, et cetera, et cetera. Very committed to diversity in all senses of the word. so that we have all areas of the metro area represented by people from those areas. And it's a clearly nonpartisan. However, he makes the recommendation and Metro Council must ratify that. So that's the process. People can come to the meeting and et cetera, et cetera. And as you know, I generally call on board members first and then our community advisory board members so that everyone participates. So stay tuned for updates on that. And then a special welcome to Dr. Anita Bhatia, the incoming Vice President. I guess she's been crowned, she said, so VP of the Greater Louisville Medical Society, to our Community Advisory Board and our meetings as Dr. Louis Herget becomes the chair. It's traditional that the vice chair, the vice president of GLMS serves with us. And I know that she will be a contributing and engaged member. So now, Dr. Smith, our June speaker is Dr. Ted Smith, Associate Professor of Medicine and Pharmacology at the University of Louisville School of Medicine. And is the Associate Director of the Envirome Institute, also in U of L's School of Medicine. A global speaker and researcher whose work has been highlighted in internationally recognized publications, Dr. Smith is also a member of our Community Advisory Board. We know him for his public service to Louisville mayors and as the co-leader of the Envirome team, a team that has conducted landmark work in analyzing the city's sewer water system to determine whether there are any outlier particulates in the water that could serve as early warning signals for the spread of disease in our community. His and the team's foreshadowing of the spread of the COVID-19 virus made us among the first in the country to use this innovative technology and provided a model for the National Research Committee to replicate. We also know him and the team for their groundbreaking local and national outreach, clinical translational research and policies to improve the air, water, soil, and as I say, shading and greening throughout vulnerable areas. Their work also stimulates the development of preventive interventions to forestall and prevent cardiac disease, asthma, and other chronic conditions prevalent in our community. Dr. Smith works closely with Dr. Rooney Bhatnagar, renowned U of L cardiac heart disease researcher, professor, and director of the Institute, to produce this translational research policy and outreach. Dr. Smith holds a Ph.D. from Miami University in experimental psychology, as well as having completed a postdoctoral fellowship at the Massachusetts Institute of Technology. Dr. Smith, the chair yields the floor and the group to you.
Excellent. Thank you so much, Madam Chair. It's a privilege to be in your outgoing meeting. Maybe if I could start on the not topic, because you brought up wastewater, so it triggered a thought. Maybe of interest, I know Director Mendel knows that we're keeping track of bird flu, H5N1. And in fact, my colleague Lauren Anderson is over at the Kentucky Fairgrounds right now looking at their sewer system as we have a state fair and several other sort of dairy cattle oriented events coming into town. So we're trying to figure out if we can provide a little safety screen to try to determine if any of those animals are infected, because of course, a lot of animals around a lot of people is not a good situation in this particular virus. So.
Sorry, that was non-clinical. How long does it take, and do you test all cattle?
No, so what will happen is we'll test the sewage that's coming off of the livestock holding areas, and there's some complications, mucking stalls. We don't need to get into all this, but we believe that the assay is sensitive enough that when they hose off the area, that water will be able to amplify for shed virus. It's really strictly a detect, no detect, and so if we were to detect H5N1, we need to work with the health department and with the state vet to determine what actions they would be willing to take to test the animals that are there. So it's cost prohibitive to test all animals. So there is no initiative in the United States to test all animals. So we're in a situation where if there was any kind of screening available, that might help us efficiently or cost effectively figure out where there might be risk. So anyway.
Director Mendel, comment from you?
We're really excited about the opportunity to do this surveillance. It is certainly emerging pathogen, and just the ability to do the surveillance and find it before it becomes human or transmits to humans is just critically important. So just more great work with the partnership we have with TED and the Envirome.
So, and I know that Kathy is on for comms. This is what the chair is interested in doing. And so, Director Mendel, if you will work with Kathy and let's get a notice, and I don't know if it's to the media or whomever, somebody's going to have to guide on whether that's the proper way to go. But putting it on our website, definitely. And with agreement of the group, if Director Mendel, you will draft with Dr. Smith, a policy statement on what needs to be done. We've talked about it here, and I'd like to give, the chair would like to give the team, Ms. Mendel and Dr. Smith, full play on what it says, but the sense of the group here. Is everyone agreeable? Do we have any opposition to that? Can we walk ahead with that?
Chair Margulis, the head of communications from Louisville Metro Public Health and Wellness has just shared a message on the chat that says, "This is Kathy Turner. We have reached out to UFL Communications to talk about joint publicity around the state fair testing." So they are already working on that.
Okay. I would ask Kathy Turner and Director Mendel that somebody send me whatever it is so that I have it. That would be great. And we'll go from there.
Okay, and just to couch all this, we're doing feasibility work over there at the fairgrounds today, right? So I don't want to get us too ahead of ourselves, but I wanted to share that because I know you all care about the public health of our community. So we're trying to figure this out.
We spent 5 years cleaning up COVID, so
Right.
lesson
Well,
learned.
yeah.
If we're gonna
We're
make
excited about trying to
mistakes,
get in
we're
front
gonna
of
do-
something. Right. That's
Yeah,
right.
if we're gonna
That's
make
right.
mistakes, let's do a different one.
All right. It's I apologize for introducing a completely foreign topic into the program today. So let me see if I can get.
We do outliers really well, so it's hard to fluster someone in the private sector who's worked for a company that's not at the top of the list of being liked. So there you go.
There you go. Hold on. Let's see. All right. Let me see if I can share this screen.
Great.
And the answer is.
And Christina, Catalina can help if you can't get it up. There we go.
And are we full screen?
No.
Are we full screen?
No. Yes.
Now,
Okay. Yes, no. Yes. Okay.
Yes.
All right. So
Yes, we are.
now we'll start with some disclaimers. and again, thank you for inviting me back to give a little talk. So this really stemmed from a meeting that I was invited to along with Christy Brown's foundation down in Manaus, Brazil, back in late January. And the focus of that convening in Manaus was to bring some of the largest philanthropies in the world together who are concerned about food systems, and also are concerned about climate and a number of other important things, social oppression, exploitation, lots of things. But the focus was on food and food systems. And there was a heavy representation of funders who both care about the health benefits of good food and also good practices in food production. And so we have the number 2 person from the Rockefeller Foundation who leads the Food as Medicine initiative for Rockefeller. They have a joint program with the American Heart Association and the White House to better characterize, let's call it, the medicinal properties of food. It's a very, very expensive project where they're analyzing thousands of food products and for their constituents and trying to map that to human disease and aging. And so that's an exciting activity all on its own, but it was good to be with these folks and get a picture of where this community is, at least with the food opportunity as it relates to health. And so I told Heidi about that, and she said, well, why don't you share something about this food as medicine thing? So first of all, big disclaimers, I am not an expert on food as medicine. Many on this meeting, I'm sure, have some kinds of insights and experiences, and I would love to include that in whatever conversation we have so that we can all learn together. So again, I'm just trying to introduce this topic. This is not the last word on the topic. So let's see if we can make this go forward. You will find some confusion about what it's actually described as: food as medicine, food is medicine. They both really do mean the same thing. So it makes it complicated in Google searches and other things because some stuff is cached away as and some is. It seems that the preponderance of terminology is food is medicine. Just as that name suggests, it's really sort of recategorizing food as a part of the clinical enterprise, as part of medical treatment, which is not historically where food has been. I mean, unless you want to go back to the ancient Greeks or whatever, but in recent times, we haven't really thought about food as a medical intervention. And so this initiative has really started to codify and organize applications of food as a medical product. Okay, I apologize for all the words here, and I know I gave you a big long pre-read from the Aspen Institute and the White House, but I'm just going to sort of talk at a high level, and you're free to read and pick at things. But most of us are very familiar with food access issues, food justice issues, the social determinants of health. Clearly food programs are a major component of many social determinants of health interventions and screening activities. And that is important work, and that is, I think, broadly seen as the work of public health and the healthcare system that wants to be involved in public health. But that is truly about access to nutrition, often all the way down to just energy, calories. For people who really are food insecure, who may not have meals every day. Obviously it's critically important work. The sort of issue over there is, that focus is not looking at food as a medical intervention, right? That's food is a necessity, just like water and air. And so that work goes on, quite independently of the Food as Medicine initiative. Now, over there in Food as Medicine, as I've suggested here, we're looking at food, and we're asking the question, when does providing food make a difference in a health outcome for somebody who is vulnerable, somebody who is currently, diagnosed with a chronic disease often an expensive disease. And so there's been a lot of focus in cardiometabolic diseases where, we all understand that the nature of the diet is directly related to the progression of disease, likely of exacerbations and all those kinds of things. We can paint a line between the food and the disease burden, disease risk, and health outcomes. And so the programs then, start to laser-like focus on vulnerable populations that have known health characteristics. Okay, so these things are truly related but different. And as we get into kind of some of the goals here, we can start to see, whether there's going to be a both, or over time, whether we're going to see sort of one component of this, kind of set of solutions sort of running the table. Okay, so as we said, reduce food on the social determinant stuff. We're really focused on the basics, blocking and tackling. On food as medicine, now we have to focus on what the actual measured outcomes are. And so one of the frustrations sometimes with the food access programs is that the level of program evaluation isn't always as rigorous as it might need to be to change policy. And so as you move food into this other frame, the medical establishment frame, where evidence of efficacy is a requirement for payment, it really does raise the table stakes, if you will, for the work. And so it's not good enough to say, somebody's happy or, is less food insecure. You're looking for harder readouts. Are they less likely to be rehospitalized? Are their blood lipids stabilized? We can go a long list of things that sound like the things that drug manufacturers care about. And they are the things that drug manufacturers care about. So, you really now have to think of these food products like pharmaceuticals, because they're being asked to deliver the same kind of evidence to payers, or the scientific community more broadly, right? Just as we try to understand what works and what doesn't work, it's a much higher bar that food is being subjected to. Okay, and we're in the, call it, first decade, first 5 years of serious evaluations of these food programs, and so we're really getting a lot of evidence back, very mixed evidence. Sometimes things work, sometimes things don't work. Shouldn't be surprising, right? That's the nature of science. So major categories of these food as medicine interventions, just as they sound: medically tailored meals. I think we're all very familiar with services like Meals on Wheels and other food meal delivery programs. Medically tailored meals, just as they sound, are not that. They are meals that are prepared, but they are prepared with a target patient with a target condition in mind. And so, to oversimplify it, diabetics, have to be careful about their carbohydrate mixes, right? And those kinds of things. So they're going to get a different meal than whatever Meals on Wheels was delivering this afternoon, probably. And the idea being, I'm going to charge the insurance, I'm going to charge Medicaid, or I'm going to charge a private insurer for this medical meal. So it needs to be prescribed in a very specific way. Medically tailored groceries, sort of a broader concept, but the same thing, very specific foods for a very specific patient population. And produce prescription programs, which there are quite a few of them across the country, that is a little less laser-like focused, and it's a little more on the macronutrients, right? Just, really focused on the benefits that we know dietarily we get from fresh fruits and vegetables, and making sure that vulnerable populations that are medically fragile are not missing the important benefits of those food products. Of the three categories, the evidence is weakest over in produce. Really, I think because, again, we're not clearly lining it up with a mechanistic hypothesis necessarily, like how much kale or how much broccoli. It's not the same kind of dose response science that I think those first two tend to be in. But that's not to say that there's not been value in it, and there certainly are programs where people are getting to better health by having access to fresh produce. The real question becomes, will it pencil out for the actuaries, right? Will it justify those costs? So Scaling is the probably number one concern of the healthcare system as it relates to this. So if you take food out of the basic staples category and you make it a medical treatment, none of us should be surprised. It could really increase the cost of healthcare considerably, because those meals are not grocery store priced meals. Those meals are much more expensive, largely because they're now going through the healthcare system. So there's claims and there's adjudication and there's, evaluation, and there's a whole layer of administrative cost that is now put on top of food in order to justify the expense, and that makes the expense go up. So we have a big date with this, I think, as a society, how much of this is going to be assumed by the healthcare system and by the health payment system. And so this is something I hope we're all going to pay a lot of attention to. And as we look at food pilots and food projects in our community, to be putting a critical eye towards, the effectiveness of these programs, and really being, when they're effective, we want them, right? And we know that there are other benefits, and there's certainly other cost savings, certainly to the healthcare system, but to society more broadly, if we keep people healthy. But there's also a great opportunity to inefficiently buy a lot of food and call it medicine. And so we were going to want to keep an eye on that. I like this graphic because it, sort of shows this continuum of how to think about food. Really the focus of this is the top of the pyramid. There's a great history, obviously, that's closer to the base of the pyramid in this country as we think about food. But the growth in the investment and activity is currently in those top three chunks of the pyramid. And so, again, this is just something for us to wrap our minds around. I mean, they're all important, but the energy is sort of shifting with a bright spotlight on these medical interventions. As I mentioned, the payers are in the mix here. So if you want this to be part of healthcare, the people who pay for healthcare need to be involved. And so the 1915 Medicaid waiver is the number one controlling policy document. Many states across the country have used their waivers to provide coverage for medically tailored meals and groceries and produce programs. Kentucky is a mixed bag. There have been, I believe, a couple of projects, and I believe the waiver is, somebody here may know more than I don't believe the waiver is fully institutionalized for broad coverage across the state. I believe that we're still in pilot projects approved by the state's Medicaid office. Again, could be wrong. The private managed Medicaid market is very active in this. So all the large managed Medicaid providers have some little project going on somewhere in the world, somewhere in the United States, using the flexibility they have to do sort of value-based activities to try to lower overall costs so they're within their own financial tent. So a lot of money is not flowing directly from Medicaid, but it's actually going through managed Medicaid pilots right now. And of course, where I work, there's an awful lot of institutional philanthropy and federal funding from NIH and the CDC to stand up clinical trials to figure out whether this stuff works. And so all three of those things are kind of in play. And I read the journal articles, and on any given one could be paid by any one of those three. I mentioned there's a high stakes focus on what we're getting for what we're paying for, and this is really going to be difficult. Most people that are much closer to this field than I am recognize that this isn't like drug development, that it is a lot harder to figure out which foods have which medical benefit for which population. So it is going to be, I think, a mess until I think the science catches up with the policy environment. So again, if you have congestive heart failure, or you have advanced diabetes, what exactly should be in the food that you're eating? Where should that food, come from? How do we have certainty about how much of it you should eat and how active you should be? And all of these factors are critically important to those outcome measures. And so I'll just leave it for this discussion. Along with the growth of this activity in the healthcare system, there will be a growth in research activities to try to demonstrate what actually works. And I really do, I would predict that we will go from the most expensive diseases that are metabolically related and work our way back to more garden variety, diseases. And that would be the adoption curve for these programs. So very specific kinds of foods and nutrients early on that are proving their worth, and then slowly expanding as we get confidence in working with food medically, as physicians and other clinicians get used to dealing with food, that we start to really mature in our understanding of how this actually works. Limitations, there's many of the usual suspects. So, the adoption of these programs, or even the picking of the pilot locations, has significant socioeconomic barrier issues, equity issues. A lot of these programs are just trying to get the work done, and they don't want a lot of risk in how to get it done. So implementation risk, like how do you enroll somebody and how long can you keep them? Those are the same concerns that clinical trialists have. And so here we are, like if you go into a neighborhood that is truly burdened, it may be difficult to keep a cohort of folks engaged in a program for a long enough period of time to evaluate results. So what that results in cherry picking places where they know they can keep people for a long time. And that's then, of course, inequitable and unfair. So big challenges. The cost issue is a huge issue. And in the conversations I've had with some of our managed Medicaid payers, they're very concerned that they don't know how this is supposed to work. And they're maybe not convinced that they're actually going to get the savings because of the wide variety of other challenges that many in the Medicaid population have that could also impact these same outcomes, right? So if it's a return trip to the hospital, laying it all at the foot of an artichoke, may be a pretty unreasonable way to think about this. And so, this is also a difficult frame to evaluate things, but also this part of the population will benefit the most immediately. So, it's the right thing to do, but it's a hard thing to do. Let me just move ahead for the sake of time. Our interest over at the Envirome Institute is nutrition. For us is an area that we have been doing some work in, and we are growing our footprint. And so, really, this is just informational advertisement for everybody. So, we're building a new campus downtown on Muhammad Ali Boulevard between 4th and 5th. That's a very expensive project that is fully funded, and we are going to build a research kitchen as part of that. There'll be a nutrition research program, and so we'll have facilities by 2026 here in Louisville to design meals, to test the components of meals, and to run clinical studies to determine the efficacy of those meals or groceries. And so this is, I think, going to be a great opportunity. We have a lot of challenges in this city, and I'm really hopeful that we can together, all of us here together, work on these challenges to try to figure out where we can make a big difference early with food, and work through the complexities of sort of how it gets paid for and how it gets administered. So with that, I wanted to give time for questions. So hopefully we have some time for questions now. Thank you.
All right, the chair yields. And what we're especially interested in, Dr. Smith, and this will come as another shock because I'm anything predictable, and that is policies that this board needs to approve so that it can be used in advocacy with the mayor and others, council members, etc. So can you forward those to Arlena and me?
Sure. I'd be happy to give some initial thoughts.
And
sure.
what do you think those are so that the board has a good idea and we can get a sense of the board so that we could approve them here and then they can go out? As you know, I'm into expeditious.
Well, sort of what comes to mind immediately is there are a number of projects that are really good projects going on in Louisville right now. There's the Kroger meal delivery pilot that's running now. I would encourage us all to think very critically about whether, with the current food infrastructure that we have, whether there are a few sort of critical learning activities. So can we when we create these programs, can we make some room to figure out where there is medical benefit? And, you know, I think, you know, so as a policy matter, it's really just sort of adding, and that's not uncommon in a lot of kinds of policies, right? To say, if you're going to do something, you should also evaluate it. And my, you know, my appeal would be to evaluate it with an eye toward its value to the healthcare system or the healthcare cost system, so that it helps people get courage when they run out of money for their pilot and they say, I guess we can't afford to do this anymore. I mean, like, well, maybe we can afford if we're really paying attention to places that are external, right? Externalities that
Okay,
the food
so
is
let me
providing.
say this differently. A piece of paper that has specifically from another city, which is best practice, directions to the city on what they need to do. Very simple.
Yep. Well, we're early
Okay.
on, Heidi. I don't know if we're at policy at this point in time, but
Right. But I mean, what needs to be done, but not research. What I'm trying to do is to figure out what the city can do to measure it. And here's the evaluation tool. I see you, Dr. Dutty.
and Dr. Shaw has a question too.
Okay.
Thank you so much, Dr. Smith, for your presentation. And I do agree with you. Food is, you know, nutritious food is medicine. And I see your presentation and the program that you are sharing with us as a treatment for already, you know, present diseases. But I would advocate for nutritious food as preventive tools for disease. So you mentioned it, urban farming allows, you know, the availability of nutritious food for several communities, African American communities, refugee communities, migrant communities. And I would advocate, first of all, for the availability of nutritious food to those communities, and then keep on going to trying to use food as a treatment for established diseases. Without a doubt, nutritious food are gonna make a difference, but I would go even before using food as treatment. I would use it as prevention for problems with our health.
Yeah, completely agree.
So, Dr. Smith, if you will give that to actually to Director Mendel, who can get that sort of on the street. I hate to use that term.
Sure. I still see a
Remember-
question from Dr. Shaw.
Yes, I see it too, but I want to
Just
be sure that
Making me
we have.
anxious looking at that yellow hand. It's making me anxious.
I know, but I believe in deliverables and not just words.
Yeah.
So, thank you. Now, Dr. Shaw,
Dr. Smith, thank you for doing this important work. I mean, I
do you have
agree
video
with,
ability, Dr. Shaw?
I think I'm on video. Am I not on video?
No.
Oh, weird. I see on video.
Yes,
There you are.
thank you.
Weird. I don't know what happened there. So thank you for doing the work that you're doing. I mean, it's definitely very important and a key sort of factor. And I know that's been said. One of the things that I've sort of seen folks run into, right, when there are limited dollars, is how do you show that food truly is important, that it's not a confounding factor when it comes to other research things, right? Like you use CHF as an example. Like, how is it that, hey, it's not the meds that are actually helping the patient, but truly the less salt? Like, we all know that. But how do you show that and sort of dedicate dollars towards this important sort of task? Was one of my questions, and I don't know if you've already thought through that.
Well, no, I mean, the quick answer to that is the kinds of trials that need to be done will have people on meds and have people on these medical meals and powered to discern the difference, right? And those trials haven't been done. And so, you know, that's when we look at Rockefeller and we look at HHS, you know, there is some hope that we'll be able to pick some of those high value areas to get some clear early evidence that, you know, and I doubt it is the food or the medicine, right? Like, or the pills, right? I mean, it is highly likely both. And the real question is, how do we tease that apart to figure out what we should be paying for the different parts, right? but no, it's work that needs to be done. You're asking, I mean, those are the right questions. Like we gotta get the evidence we need.
Dr. Miller? Thank you, Dr. Shaw. Good question. Dr. Miller?
Thank you. Dr. Smith, I wonder if you think that, you talked about looking at specific diseases in specific states and finding food, if there was a specific food that could cure. But if you think that rather than being so specific, I think, in pregnancy, we talk a lot about the impact of stress on pregnancy. And I think food insecurity is a state of chronic stress as opposed to the other conditions that accompany it, hypertension, diabetes, and such as that. And we are doing a lot of work on food insecurity and preterm birth and using those obstetric outcomes as our deliverables. But do you think evaluating chronic stress as what food insecurity is healing and these food interventions are healing is too broad to kind of push this to a broader audience and an insurance audience?
I'll just give one person's opinion here, right? So, but it's a great question. I think we tend to try to use a frame of what would I need to show you to demonstrate that, right? So in the case of chronic stress, will we be looking critically at stress biomarkers as an important part of telling that story? And I mean, I think it's extremely plausible, right? I mean, the world's a complicated place, and there are a lot of these things interact with each other. And so I think that's a different version of the kind of trial work that needs to be done, right? Where we're not just looking at the food for its chemistry, right? Now we're looking at food for its other properties, right? Which are potentially more powerful, right? I mean, so I completely agree with you. But my experience with working with the healthcare system has been, you really have to sharpen your pencil and make sure you have all of the stuff, all the evidence laid out. And, because it's not, these actuaries don't suffer fools, right? So they really, they don't, it's not a faith exercise. Like, they want to know that you've done enough work. And of course, by the time you get to medical guidelines, it gets even more complicated, right? So to say how much for who, I mean, which is the pillar of medicine, right? How much for who? I think, your work, thank you. I'm very familiar through Dr. Sears of the work that you're doing. It's really important. But my hope is that we get to how much for who, so that people get confidence that we understand how food works. And I think that's what's in the balance here. Is, sort of our skepticism that we really know about food.
I'm sorry, one more. I think that food is medicine, food is education, food is all things. I think that a lot of our work stays so narrow and we stay in this medicine realm, but we should be broadening this out to, like, how do these kids do in school? Are there improved outcomes and things like that? Because that has long-term outcomes on their health as well. But we stay so siloed in just like these conditions and things like that, we don't see the long-term picture.
I love that. I mean, yeah. For me, it's always been about how do you get the externalities, right? So if it's education, who's paying for education, and how do we help them understand that food is education, right? I mean, and that's just the tragedy of our current times, right? Like, finding somebody to pay for it, really is a full-time job, to make this stuff work. And but I completely take your point. It's such a good point.
Another question. Thank you so much. That was very helpful. And I know the chair notes for the record that Deputy Mayor George has joined us, and welcome. And we'll go to you momentarily. Other questions? Okay. This was outstanding. Thank you so much. And not only that, for tremendous contribution. And I think we will want folks back to talk about the state fair and learnings from there, because we learn more and the most from our negative experiences. And it's a positive effort, but let's see what we learn, taking the lessons that we've had in the past. So thank you very much. And please do stay on if you can. The chair is going to recognize Deputy Mayor George. And poor Deputy Mayor, she is, the good news is she lives by one of our beautiful Olmsted parks, so do I. And the bane of my existence, the chair's existence, I live directly, I mean, my view, if I turned my camera around, would be Cherokee Park. The racing and revving of motors of ATVs, which are outlawed, I note. And the police have done nothing. The chair had never in her 70 years ever appeared at a police station. I have made, I believe, 3 visits, on-site visits, not to mention the phone call so that it could be reported to Division 5 on Douglas Boulevard to report its teenagers racing through the hills here. Anyway, poor deputy mayor, but she's an operator. She understands and has the best interests of this community. We could not be better represented. And I would encourage, if you have issues like this, that you each contact your council member, which I did through Ben Weber, and then the master, I call her the COO of the Metro government, based on her experience and her delivery. She is accountable. So also the mayor yesterday or day before introduced an initiative for safer parks. These all sort of collide, if you will, in terms of looking at our environment as a whole. So Deputy Mayor, DM, the chair yields to you.
Thank you, Chair. And I just want to say on the front end, a big recognition for your 5 years of service and your position. Both the Board of Health and obviously our community are the better for your work. And I think what you have highlighted in the way of making the connections between misuse of some of our park space, particularly around ATV use, is a public health issue with real health and safety impacts. That, as you mentioned, Mayor is committed to giving focus to. You know, our intention is to make sure that our parks are healthy and safe and accessible to all neighbors. And so that means both finding new strategies to activate and to inspire positive use. And it also means, quite frankly, addressing the illegal, illicit, criminal opportunities that have been happening in some of our parks that we have to be upfront and honest about. And so it is that combination. We're really fortunate to have the support of Bloomberg Harvard and having a really strong collaboration between both internally within Metro as well as with our park partners. But again, your leadership has helped us make some of those connections. It's one of those things a lot of people wouldn't think about, like what's the connection of ATVs? Well, if you don't feel safe being on a trail in a park, you're not going to be able to access that. You're not going to be able to use it. You're not going to feel safe. Also has impacts for neighbors who live closest to and within proximity. So certainly a real issue. We are working on solutions. If it were easy, it would have already been done. But please, you know, more to come on that. The only other thing I wanted to mention and elevate, and I don't want to steal the thunder of our public health leadership, they have done tremendous work in the last month, specifically on both Juul settlement dollars, on opioid settlement dollars, getting those things passed and moved through the council. The fact that there was, you know, no points of contention with council members is a real reflection of their good work and the groundwork that they laid. And then also just in general on the budget, they had their budget hearing this week. Connie, Stacy, and Nick did a tremendous job. So anyway, this is all. I'm so glad to see everyone.
Terrific. And I would encourage a conversation with your colleague, Bill Royale, the chief of police, because there's a lot of talk and no action. And beyond disappointment for the health of the community and wherever, but nonetheless.
So I'm sorry, I just want to say, I feel compelled to say that yes, chief is aware, and I think it's helpful when neighbors also, you know, elevate and echo.
Correct, which has been done. Mhm.
because they're managing, yes, because they're managing a lot. And I would just say, please know that as it relates to our park initiative, Lieutenant Caleb Stewart has been fantastic in helping us find very specific solutions. We picked arenas, you know, Bloomberg recommends you start small. So we've picked 2 parks. Iroquois Park is one intervention site. The other one is in the Russell neighborhood. And so, you know, the important thing to know is that we are, but please hear me say there is work to be done on ATVs. And yes, we will certainly continue that conversation with LMPD, and there is good work happening.
Yes, and big salutes. The root cause clearly is if you move people from one place, they are like amoeba. They go somewhere else. And I worry that if we get them out of here, they will go somewhere else. But great effort, and don't mean to in any way demean that. I also want to see, and you may not be the right person for this, but the community of care downtown and the center and the homeless. Did you want to say something about that?
Oh my goodness. Well, if you guys are, and I don't know, forgive me because I'm on my phone, I don't know who's on the meeting, but VOA has put forth their design concepts, and that's done in conjunction with Miranda. It is very exciting work, and being able to see it, you know, on paper in terms of concept is really important. And so people can go to the VOA website and see what that looks like. Again, it offers opportunities for medical respite. It offers opportunities for family shelter. In fact, that's where they'll be starting, just because it's it's the easiest conversion of space. Permanent supportive housing. VOA proposes to move their headquarters there. That is the plan, is to be able to use an existing space that's kind of difficult, turn that into both their headquarters, but also allow for other services to be there in the spirit of being able to serve Smoketown. And we're having really great partnership with our neighbors on the block. We met with Salvation Army last week. We have ongoing partnership with the Recenter in the area, ongoing work with Hope Village. And so all this to say, we're at a really great place. We're moving towards a development agreement with VOA, which will then allow for construction to start. And so fortunate to have a $22 million investment from the state, which is going to be incredibly helpful and have really strong partners. And so all that to say, very excited about that. And Chair, I just want to say, in terms of like this idea that when you move people, they just go somewhere else, I think what we're looking to do in the community is inspire a little bit of pressure to inspire behavior change, right? And so while you can't do that for everyone, we are convinced sometimes that when you apply that pressure and you set that boundary in the community, always offering connections, but establishing boundaries too, that there is the opportunity for change.
That's perfect. And I remind folks that this is being streamed live on Facebook and available out there. And Kathy Turner, through her media contacts, etc. One of the reasons for some of the pressure that I've articulated is that for people who are listening, and if any media listens, and usually WDRB or someone does listen, that they can help us by spreading the word through public information that it's being patrolled and monitored, and we have this effort called Safer Parks, and et cetera, et cetera. So that is a really good thing, and one of the reasons why the tenacious gene that I have comes out as passionate as it does, because this is and this is for people's health, but the efforts and the initiatives are outstanding, and we thank you for years and years and years of service. Okay, questions, comments? Okay, so Connie Mendel, any quick action items?
Sure, yes, thank you. Good to see everybody on the call. You have in your board materials a copy of this month's report from the department. I wanted to point out a couple of things quickly. One, again, we're so excited about the renewal of our Healthy Start grant and programming. So we were recently awarded $1.1 million, and this will be over the course of that amount per year over the course of 5 years. So, and there's another organization in town who's also receiving Health and Human Services funding for Healthy Start. So because of this, we're expanding our zip codes. So we'll be in zip codes 40203, 08, 40215, 18, 40258, and 72. So that includes areas within Newburgh, Valley Station, Pleasure Ridge Park, and Hazelwood. As we continue services in Portland and Park Hill and Algonquin. So just super excited. So what I'm asking for you is to help us share this exciting news. Healthy Start is an educational home visitation program. So this is one of our maternal child health programs looking to reduce and further and eventually eliminate the health disparities related to maternal and infant, which sometimes unfortunately can lead to death of both mom and baby. So we want to remove barriers. We want to provide services. We're connecting families to prenatal care, services like doulas, food assistance, emergency supplies, transportation, housing, and more. So critically important. Next point I have and ask is related to our community health needs assessment. We've extended the survey to the end of June. So if you haven't had a chance to do that, please do, and please share that. You know, we want the voices of our entire community. We want all neighborhoods represented, all of our residents represented, so that, you know, just as Chair Heidi mentioned, as far as board representation, we want all cultures, views, races, nationalities. We want everybody represented in our community health needs assessment. Also want to share, in your notes, you'll see a fatherhood event. So as we talk about maternal child health, fathers are an important part of that, as we all know. So June 24th, we'll have a fatherhood event with a resource fair. Dr. Perry from the University of Louisville Kent School of Social Work will be working with us. That is June 24th, 6:30 to 8. Details are in your report. And again, there's many other things that we're doing that you have the information. I'm happy to share more information if you have questions. Lastly, still on the topic of child health is we did a pilot study for prenatal blood lead surveillance. So we're trying to identify lead early within our pregnant parents before childbirth and before we see the serious impacts that blood lead poisoning can cause. So there's some of the results there. If you're looking at that, 15% of our prenatal tests came back with blood levels over 1, but less than 3.5 micrograms, and 2% of the people that were tested were above 3.5 micrograms. So this is certainly at that level is concerning, but no amount of blood is safe, particularly for during pregnancy and within infants and small children. So we're looking to expand this project. Would love input from our board members of how we can expand the lead in pregnancy project so we can do more screening, particularly for those that live in our high-risk geographical areas. So those with housing before 1978 that's at risk for lead exposure. So I know that was a lot of information. But
let me cut to the chase here as well as an operator. So we identify it. What's the action that we take, and how are we measuring whether we're able to bring it down or get the houses painted, or what's the solution here, and who's working on it?
So the solution is within our childhood lead poisoning prevention program. So we identify someone with lead, then we do a risk assessment of the home.
Right.
Yeah, so we look to where the lead exposure
that part
is.
I understand, but let's say we pretty much know that we have a problem. How is it corrected?
Well, fortunately with Lead Safe Louisville and our work with Community Health Services, there is HUD funding available for lead abatement of homes and rental property. So, and there is federal funds that some years go unspent. So we need to identify the houses with that have the issues and get those funds and get it corrected.
Okay, so the accountability, because I don't think the residents are capable of that.
The city will take for the work.
Yes,
Yeah, HUD is with those HUD funds that, yeah, the work is completed through qualified contractors.
perfect, perfect, excellent. And if we can have a report that says, you know, there were 50 homes
Mm-hmm.
identified on this date, and on this date, they were painted or fixed or whatever, and they're going to be monitored for 6 months, a year, or whatever,
Yeah.
that would be helpful.
Mm-hmm. And this also ties into our lead rental registry.
Right, and we
So,
also, I
yes.
think, had made a policy change on that got
Mhm.
into the requirements, right?
Yes, yes.
Proud
So
of the
we're
board on that.
a lot of work being done around lead poisoning.
Cool. Makes me smile. Thank you. Okay, now, if there are no questions, I will go to committee chair updates and 2 minutes, family health centers, and just the health centers, family health center, and then Ms. Shoemaker for the Medicaid issues and the coverage and reinstatement, et cetera, et cetera. Dr.
Okay, well,
Gould,
thank you.
2
Yes,
minutes.
to mention to the board that Family Health Centers, while being a 501c3 organization, is also a component of the Board of Health and carries out the Board of Health's work. So here's some information on what some of the trends that are happening. Deputy Mayor George mentioned the community care campus and the respite program. Family Health Center currently operates a respite program at the Wayside Hotel on Broadway. I'm happy to say we're joining with Norton Healthcare System and U of L Health to expand that program on the community care campus. So that's an exciting development. We also hope to provide a higher level of care at that site.
Congratulations and thank you.
Yeah, it's exciting. Wanted to mention some demographic information about Family Health Center patients. We have 2023 data now. So I'll go through those quickly. 89% of the persons we served were 100% of poverty or below. 25% were ages 20 and under. 11% were homeless, and we're talking about over 4,000 patients there. 24% or 9,000 patients were uninsured. 40%, and this perhaps is the most important data point that I'll share, 40% or 15,000 patients were limited English proficiency speaking patients. That means they required interpretive services to provide comprehensive care to them. And the prevailing 70% of the LEP patients were Spanish speaking. We also had Swahili, Kinyarwanda, Somali, and Arabic were prevalent languages as well. We say there are serious challenges associated with providing care to non-English speaking patients, and that is the cost of interpretive services. Family Health Center spent $1.6 million last year in providing these services. Is fairly uncompensated care. LEP patients take twice as long as English-speaking patients to serve, so we're able to offer less appointments to our patient population. And fewer LEP patients are covered by Medicaid, which is one of our primary sources of income. So there's some serious challenges that we're having in serving this population. One strategy that we're using is to recruit Spanish-speaking staff, physicians, nurse practitioners, dentists, etc. If you know anybody who speaks Spanish and is interested in working with indigent patients, please send them our way. We could certainly use their assistance. Any questions?
Excellent report. Questions for Dr. Irwin? Okay. Excellent. Is Ms. Shoemaker on?
I'm here. A quick update on the Medicaid unwinding. The unwinding for adults is officially over. So all adults have gone through their renewal period. There is still a 90-day redetermination period for people who have not submitted documents and had their coverage terminated within the next 90 days. If they submit their documents, their coverage can still be reinstated. But going forward for adults, they will need to renew their benefits on an annual basis. Statewide, about 180,000 Kentuckians lost Medicaid coverage during the unwinding. I don't have the numbers yet for Jefferson County, but I should be able to share those with you at the next Board of Health meeting. And then the child renewals are on the horizon. Kentucky was a model in the nation for making sure that children stayed covered. We were the first state to implement continuous coverage for children, and so we have not seen the large numbers of children losing coverage that other states have seen. But those Medicaid renewals for children are going to start this fall. Starting this September, children will need to complete their renewals. So that will start in September and run through May of next year. And so we definitely have our work cut out for us to make sure that children are able to maintain coverage. So we will have our next meeting on Monday, the 10th at 4 o'clock, where we will be discussing, outreach efforts to make sure that children maintain coverage.
Perfect. And just a ballpark based on your experience of the 180,000 who lost coverage, is Jefferson County about half of it, 2/3 of it?
I'm not sure. I don't think I have a good estimate for that. I don't want to put something out there and it be wrong.
Yeah, I agree with you. No problem. I'm going to try to join in on Monday. Any other questions? Dr. Bhatia?
My question actually was for the earlier presentation by Connie. I had a question when you talk about Healthy Start organization. That was wonderful. Because I don't know very much about what's going on, my question is there such an organization, and there might very well be, that looks at the elderly and their readmission rates that we talked about, where I link it also to the food as medicine talk. We definitely find that heart failure is amongst the most common public health problems, and you're probably very well aware of that, and that causes the maximum amount of readmissions in hospitals, and it's food related and it's health related. So what awareness are we, I know we give them big instructions of what to do and all that, and they sometimes follow, but it's very simple. They didn't get their meals the night before, or they ate a big pizza the night before, and without any knowledge of what the salt content on that is, and they have forgotten to take their diuretics. So what kind of this thing do we have other than home health? What do you all provide? And that's out of curiosity. I have no idea.
Thank you for your question, and all the points that you make are excellent. We do not currently have a program servicing elderly health, but that's something that I would be more interested in discussing with you to see what is available in the community and how we can augment that.
Director Mendel will be in contact with Dr. Bhatia and set up a full conference call or something like that. That would be great to get her briefed.
Thank you. Appreciate it.
Okay. Watching for time here. So I'm going to sort of combine all of these because the goal is we have about 5 minutes to go. Dr. Carrico, net 1 minute.
Sure. So I think the report from our local meeting is included with the board materials, and we should have a plan of action within the next 2 weeks that will outline our specific goals and timelines for the work. I had the luxury of spending a little bit of time with the new dean at the U of L School of Public Health. That was a wonderful meeting. There is such tremendous interest in immunization. So we are making progress, and hope then by next month we will be able to outline our action plan more fully.
Thank you so much. And
Yes.
Dr. Eccles, anything to add?
Nothing specifically at this time, but
Thank
just to
you.
thank Erica for
Let's see, community advisory board members, any announcements, strictly action items from GLMS, KNA, JCPS, which is not on, Gilda's Club, any action item. You're muted.
Sorry, I'm driving. No, nothing for
Just be
Gilda's Club
careful.
at the moment.
Okay, appreciate it, and appreciate all that Gilda's Club has done. I'm a bit conflicted as I'm a board member, but regardless, they have a West End branch and are doing wonderful outreach in the community to bring their healing arts, so to speak, and clinical knowledge to people, as well as faith-based care and partnering. So the partnerships we hold with faith-based organizations and organizations like Catholic Charities that encompasses a great deal, those are really very treasured, because we do know in vulnerable communities that faith-based institutions are a primary influencer, as well as gathering place, as well as where food's provided, and the list goes on. Medicaid Coverage Coalition we dealt with. Is there any old business to be brought before the group? Okay, hearing none. Is there any new business? Anything we've missed? Any announcements of clinics or etc. That we need to know about? Another reminder to board members whose terms are appointment terms are ending. One serves until the ones are appointed, and we'll stay in touch on that. Okay, a final reminder: the July meeting is a short one for election of officers and any other necessary business items like approving the minutes of this meeting and any directions for the first meeting this fall, September 4. Anything. This is final call. Well, I want to say how much I appreciate all of you. This has been and will continue to be one of the most inspiring opportunities of really positively disrupting a system and leaving a system better than we found it. And I serve with honor among all of you. We have had near perfect attendance over the past several years. I'm awed by that, because it's not that you don't have, quote, real jobs or real roles, but the role that you play, I want you to know, is making a lifelong difference in people's lives. And it's economic well-being, it's health well-being, it's all facets of the determinants of health. And for this woman who has spent a life, comes from a family that was in public health. And my daughter was actually in West End. It is squaring my family circle and giving back to my hometown and really explaining life and death, which is different than the life and death I was living in my work or pay life. So thank you for this opportunity, Dr. Bautista Rivera. My arms are wrapped around you. It's very hard to get rid of me. And I salute all of you and wish you a good season. And we will meet briefly July 10. Any other comments? Hearing none, no objection, this meeting stands adjourned. With a big hug.
Thank you.
Thank you.
Take care. Take care, everyone.
Have a beautiful